Welcome. We're happy to have you here at today's webinar, Hospital Community Benefit Spending, How to Increase Investments in Population Health. I'm Trish Riley with the National Academy for State Health Policy, and I'm pleased to be your moderator today. Today's webinar is supported by the Robert Wood Johnson Foundation, and we thank them for their support. Before we get started, let me just quickly go over a couple of housekeeping details. First, this is a web-based interaction. The phone lines support the webinar. Many of you should be able to listen to the webinar through your computers. But if not, phone lines are available, and the 877 number is listed on the slide. These lines will be muted for the duration of the webinar. At any point, you can ask a question, and we encourage you to do so. Just type it into the chat box located at the bottom left of your screen, and we will be responding to questions throughout the discussion, and most particularly during the Q&A portion of the webinar. Importantly, the slides and the recording for the webinar will be posted on the NASHB website in the next couple of days. Today we're going to focus on the requirements that hospitals document community benefit to the IRS as a provision of their nonprofit tax exemption. In 2011, nonprofit hospitals reported $62 billion in spending on community benefits. We'll learn a bit about the history of this provision, how the ACA strengthened it, how community benefit obligations can be strengthened, and through community health needs assessments, improve community health, and we'll hear a series of policy recommendations in that regard. We'll also hear about how states can do more and what states might do should the ACA community benefit provisions be repealed. We have a really terrific panel joining us today, and we're very pleased to have all of them. Let me quickly introduce them, and they're all extraordinary, so I'll just quickly give you the highlights of their distinguished careers and introduce them in the order in which they'll speak. Maureen Burns is the lead research scientist and lecturer in the Department of Health Policy and Management at the Milken Institute School of Public Health at George Washington University. Sarah Rosenbaum is the Harold and Jane Hirsch Professor of Health Law and Policy and the founding chair of the Department of Health Policy at the Milken Institute School of Public Health, George Washington. She's consulted with 6 presidential administrations, and I suspect is about to add 7 to that, and 19 Congresses, and will soon add 20. She currently chairs the Medicaid and CHIP Payment and Access Commission. Cynthia Woodcock is the executive director of the Hilltop Institute at the University of Maryland, Baltimore campus. This is, if you don't know it, it's a very important nonpartisan research organization and has done really important work, particularly around the issue of community benefits. Cynthia leads Hilltop's Hospital Community Benefit Program. So with this expertise, we ought to have a very, very important discussion. Again, look forward to your questions. Add them in the chat room. And with that, let me turn it to Maureen.
Thank you, Trish. Good morning and good afternoon, depending on what time zone you're in. It's a pleasure to be with you today to highlight some opportunities for aligning federal community benefit tax policy with community-wide health improvement. Let me thank Trish and her colleagues at NASHB for pulling this webinar together, and I'd like to acknowledge the support from the Kresge Foundation and the Robert Wood Johnson Foundation for our work in community benefit. Next slide, please. As you all know, given your leadership role in the leadership of NASHB, there are a number of factors driving change in how we think about and what we focus on when it comes to health. A growing focus on the social determinants of health, healthcare reform itself, and what we want to focus on today is the role of hospitals in improving community health, particularly expanding and refining the community benefit obligations of tax-exempt hospitals. Next slide, please. Many of you may know this, but we wanted to be sure to go over the basics as we have a conversation about next steps. But the community benefit obligation for tax-exempt hospitals has been around for a long time, and it has been an IRS compliance issue. In exchange for not paying taxes, there is a requirement that the tax-exempt hospitals meet a community benefit test. In 1956, that was defined really focusing on charity care. If someone comes to the hospital, can't pay for their care, the hospital will cover those services. Many years later, in 1969, the IRS broadened the categories of activities and investments that a hospital could claim as community benefit when it reported to the IRS. It went beyond charity care. It included things like a Medicaid differential, health professions training, research, and importantly, a category called community health improvement, which we'll talk a little bit more about as we go through the webinar. But it wasn't until 2009 where tax-exempt hospitals actually accounted, if you will, to the IRS for how they allocated their community benefit dollars. So of the total amount of community benefit dollars the hospital would spend in a given tax year, since 2009, the hospitals have to attach to their 990 tax form something called the Schedule H worksheet, which reports on how much of those community benefit dollars are allocated among the allowable categories. Next slide, please. For those of you who haven't seen the form, we just included this in the slide so that you'd get a feel for what it looks like. And importantly, if you could just keep in mind as we go along the fact that we've shown this in two different sections. There's a section 1 or a part 1 where the hospitals report on the spending in certain categories. And then the hospitals report in a different section of the form on something called community building activities, which in fact include things like housing, environmental health issues, workforce development, the very things most of us would identify as being very important investments when it comes to upstream addressing root causes of the health issues in a community. So if you would just keep that in mind, the hospitals today are reporting on those activities in a different section of the form, and it's partly what we want to address as we talk with you about maybe some suggested changes that would make it easier and even encourage hospitals to be investing more of their community benefit dollars in those kinds of activities. Next slide, please. Just to give you a flavor for, and Trish mentioned this in terms of the $62 billion number, but just so that, again, we're all on the same page, greater than half of all U.S. hospitals operate as nonprofit corporations, so there are a lot of them. Between 2002 and 2011, the national value of tax exemption estimated to nearly double from $12.6 billion to $24.6 billion. And as Trish mentioned, the IRS reported that the hospitals themselves have reported that they've been spending $62 billion in community benefit spending in 2011. So that's a one-year number. The point of including this slide and referencing these numbers is to show you the scale and magnitude of the dollars that are spent in community benefit. And for those of us who are interested in public health investments, the idea being that even a small increase in the kinds of activities in the public health area, social determinants of health, upstream activities, would make a big difference since the denominator itself is large. Next slide, please. Again, as I'm sure most of you know, in addition to all of the various things that the Affordable Care Act brought to the health care system and health policy, there were provisions included in the Affordable Care Act that dealt with community benefit and with hospital compliance. We've listed those. We don't want to suggest that the only thing in there was community health needs assessment, accountability, and transparency. There were a number, as I said, with all of you on the webinar. I'm sure you're familiar with all of these. We're going to focus today on the requirement that came with the Affordable Care Act that not only would the hospitals continue to report on their Schedule H worksheet in terms of how they were allocating their dollars, but the hospitals have now been required since passage of the ACA to conduct an annual a community health needs assessment every 3 years. The point of that being working with community partners to identify what are the needs of the community, the understanding behind these provisions being important to understand what those health needs in the community are if you think about effectively investing and spending your community benefit dollars. So to be clear, and again, most of you I'm sure know this, in the Affordable Care Act, now hospitals are required every 3 years to conduct a community health needs assessment. They need to adopt an implementation, and that community health needs assessment must be made publicly available, and that usually means being posted on a website for the hospital. They're also required to adopt an implementation strategy. What's the plan for addressing those needs that were identified in the CHNA? That plan has to be approved by the board of directors of the hospital. The idea, again, being behind these provisions, accountability, transparency, and beginning to really push hospitals to link community benefit spending with the very needs that are identified and present in the community. Next slide, please. What some of us, in partnership, I'm sure, with some of you who are working with your hospitals, observed is that what was missing, if you will, was easy access to knowing how a hospital allocated its community benefit dollars. So you could know what the need is, you could think about adopting the strategy, but at the end of the day, did we know how the dollars were allocated, and did they link in terms of expenditures to what those needs are? So we began to focus, with support again from the Robert Wood Johnson Foundation and later Kresge, really thinking about what are the kinds of things that might be helpful in showing a clear link between health planning and community benefit investment, the transparency in community benefit investment choices, and are there incentives to spend on community health-wide improvement. Next slide, please. So with support from the Robert Wood Johnson Foundation, we created a prototype for a user-friendly, easily accessible web resource that would allow anyone to be able to go online, put in a name of a hospital or the name of a county, to call up some hospitals to get the information that the hospitals report on their Schedule H form, so that lots of different players would be aware and knowledgeable about how a hospital actually allocated its community benefit dollars among the allowable categories. The idea being, could we see that the investments are linking up with what the needs are? Next slide, please. So this slide shows you charity care, and in 2011, it shows you how hospitals were allocating their community benefit dollars among the allowable categories. And the only reason we have this slide in here is to bring your attention to the line that's about 6 down under total other benefits, where it says community health improvement services and community benefit operations. If you go all the way over to the right side, you see that less than a very, very, very small percentage of the dollars that are being spent in community benefit are being allocated to community health improvement. To be sure, charity care, unreimbursed Medicaid, some of these other expenditures are very valid and very needed in some communities. But overall, if you look at how small a percentage of the dollars that are going to community health improvement are, it would be our observation that there are ways in which we could be working in partnership with hospitals or looking at policy opportunities, which we're going to talk about today, to really begin to get hospitals to increase their expenditures in that category. Once we worked with the Robert Wood Johnson Foundation and others to think about filling that information gap, how can we give others information about how the dollars are allocated so that they can have an informed and productive conversation with the hospital about increasing expenditures in community health improvement, we then thought, are there other potential obstacles to the hospitals doing what, in fact, we are asking and encouraging hospitals to do? So we began to look at, are there some things in terms of IRS policy that we could focus on that would make it more clear to the hospitals that, in fact, upstream investments are the state of the art, or in fact areas that would be a very good investment and link to the community health needs assessments that are identified. So we did some policy work. We have the title called New Research, but what we really did was just go back and look at the community health needs assessments that had been conducted and posted by the hospitals, and realize that as hospitals were looking at what the needs are in the community, you see that 72% of hospitals are identifying obesity, 68% identified mental health. Not surprising at all, right? 62% identified diabetes as the top health challenges in their communities. The very kinds of health issues that really lend themselves to thinking about addressing social determinants of health to get to these high rates of health challenges that communities are seeing. So I'm going to turn this over to my colleague Sarah Rosenbaum in a moment, but to next slide, in terms of current IRS policy, where I want to leave you with is this notion again that on that left-hand side, part 1 of the form that we looked at charity care, Medicaid differential, community health improvement outside the four walls of the hospital, but as Sarah will probably point out, frequently focused on clinical and a little bit less in terms of social determinants of health. Those are the things from that chart that we were looking at in terms of how hospitals allocate their dollars. Where investments are made when it comes to the social determinants of health, housing, environment, workforce, they're reported on another section of the form. IRS has been very clear that if a hospital points to an evidence base that demonstrates that that investment in fact can address one of the health or some of the health issues in a challenge, the IRS has said it would be allowable. However, that requires an additional step. I think there are questions about what evidence might be sufficient for the IRS. There are a variety of things where clarity from the IRS and potentially a way to be clear with the hospitals that there's no disincentive or obstacle to actually spending community benefit dollars in that area is what we've been focusing on now for the past 9 months to a year. So Sarah, let me turn it over to you at this point.
Sure. Thanks, Maureen. So again, not to beat a dead horse here, but if you look at the totality of current IRS policy when it comes to community benefit spending, what the IRS is really focused on, other than perhaps research and health professions training, is activities that benefit patients. And of course, arguably research and health professions training benefit people we call patients. So charity care, financial assistance, unreimbursed Medicaid costs, all focus in on what hospitals are doing for their patients. Even community health improvement, if you look at the IRS definition, looks at things that are generous to people who assume or assume a patient-like relationship. That is, they're getting something that we might think of as clinical or patient support services from a hospital. There might be a free nutrition education class for people with diabetes who get their care at an outpatient clinic, or an immunization program that's free before the beginning of school. Again, the issue is the nature of the relationship between the hospital and the recipients of its beneficence, and understandably, of course, where the benefactor is a hospital, you would expect that tax policy really focuses in the main on how a hospital benefits people who are its patients or who have a patient-like relationship. The critical issue in upstream spending, as it's come to be known, obviously goes by many monikers at this point, but the crucial dimension of the social determinants movement and upstream spending is that what's being talked about is expenditures that are not necessarily specific to any individual. They are expenditures that benefit entire communities, such as fixing a playground, or starting a farmer's market, or many other endeavors that that sort of go outside the realm of a clinical relationship or a patient-provider relationship. And it's this area that is sort of addressing the underlying social determinants of health that so much thinking has been done around. And of course, as Maureen noted, the IRS has cracked the door open on this in two ways. One, by having this area of Schedule H called community building, which is outside community benefit, but two, saying, well, if you think you have an evidence base for a community benefit, for a community building activity that actually we should be thinking of as a community benefit, basically document it for us. And the burden then shifts to the hospital to essentially, as a compliance matter, come in under the community benefit definition. That's of course somewhat problematic. And the other thing is, if you're a prudent hospital, you might want to emphasize those community benefit activities that are clearly within the IRS's worldview, truly community benefit activities. So this whole sort of ambiguity around community building and community benefit, a community benefit definition that is really patient-oriented, community building definition that clearly emphasizes communities but is not squarely within community health improvement. These are all areas of great uncertainties for hospitals. And the other thing that should be noted is that the Affordable Care Act, as Maureen noted, has made a number of changes in tax-exempt hospital policy, but one of them was not to require that hospitals draw a clear and transparent link between their community-wide health planning endeavors and their community benefit spending. They have to develop implementation strategies. They have to talk about the resources they're going to try and bring to bear on responding to the needs assessments. But there's no obligation to explain to a community how the process of putting a needs assessment together is potentially influencing a hospital's own community benefit allocation. So based on that, you can go to the next slide. We've identified, if you could go back to the one called IRS Policy Opportunities, or forward to the one called, yes, okay. We have identified several policy opportunities. One is to broaden the definition of community benefit to clearly include community health improvement activities that encompass community-wide efforts, to not leave it up to each hospital having to explain to the IRS why a community-wide community building effort also should count as community health improvement. Recognize how far we've come on encompassing the social determinants within the meaning of community health improvement. That's number one. Number two, we think there's a major opportunity to revise the Schedule H reporting system to have hospitals report for the public on those community benefit expenditures that they see as linked to their planning and their implementation strategy. So, you're planning on going out and raising or partnering with other organizations around community-wide health improvement, but also tell us, under this expanded definition of community health improvement, how your resources are beginning to align with your needs assessment. And a third opportunity really is to set up on a government-wide basis an advisory group that can advise the IRS on best practices for community-wide health improvement activities that the IRS in turn could essentially incorporate into its own policy. So the IRS, of course, does not have in-house public health expertise. The IRS, to its great credit, has turned on many occasions to the public health community. When they wrote the CHNA rules and they revised Schedule H, they have turned to public health experts. This is a case where public health has much to offer on the kind of community-wide efforts that have some evidence base in health improvement that could be assembled for the IRS into a practical guidance that the IRS could use to affirmatively notify hospitals and hospital systems that these are the kinds of activities that the IRS recognizes as being community health improvement activities. You don't have to give us additional justifications for them. We take it at face value that these are all good things to do, and that might also encourage greater upstream spending. So then, of course, the suggested reforms become the elimination of regulatory obstacles to upstream spending, a clearer link between the needs assessments and the community benefit spending, and finally the issue that Maureen talked about, which was the transparency. not only from the IRS policymaking point of view, but through things like the online resource that can give communities more of a real-time sense of community benefit spending.
Great. Thank you, Maureen and Sarah. One point of clarification before we move on to Cynthia. The website, two questions about the website, Maureen. One, when in 2017? And two, will it include evidence-based interventions that the IRS had previously accepted?
Robert Wood Johnson Foundation is working now with a partner to bring that web resource to be the full tool. What we know now is 2017. We don't have a clearer time, although they appreciate the interest that people have in this and are trying to get it up sooner rather than later. But stay tuned, Trish, and we'd be happy to share that with you when we get a greater sense of when that will be available in 2017. When the web resource launches, what it will show is an individual hospital's allocation of its community benefit dollars. It will answer a few other helpful questions that we think people would like to know in terms of, is it a Medicaid expanded state? Are there a variety of other, is there a state requirement already around community benefits? There are some things that would probably be helpful to know. So in addition to what the hospitals report, being able to access it in a user-friendly way, there will be some other contextual information that we think will be helpful. It also importantly will allow the user to compare. So you can compare those allocations to other hospitals in a county, other hospitals in a state, pick some factors, demographics and size, religious affiliation, so that you go into a conversation with the hospital, perhaps not only better informed about what its practices have been about investments, but how that might compare to others, so that you could point to perhaps others who are doing some things in an area that would be helpful. Initially, it will not have descriptive information in it in terms of what the hospitals have either reported in their community health needs assessment or pointed to your question, Trish, as the evidence base. The hope is that over time, and there'll be help when people go to the web resource initially to say, you should go to the hospital's website to read the community health needs assessment report. There are a couple of different resources people would want to take into account when they go to have that meeting or think about a partnership with people at the community and the hospital. But initially we want to be clear, it fills the gap where there was no other resource where you could see the dollar amounts actually allocated among the categories, so you could see whether anything was in community health improvement or anything was in community building. And that's the gap that's filled. Over time, I'm hopeful that it will become a more streamlined, you could click to community health needs assessments, you could get some of that other information. But initially, it starts with filling that financial allocation gap. And when people go to the website, will be quite clear, I think RWJ will be quite clear, that there are other pieces of information that the user will want to consult to be able to get a full picture. Sarah, do you want to add anything to that?
And Maureen, how recent will the data be? How up to date will it be?
So as recent as we can get, as the web resource, we did the prototype, it's now being built. There will be a lag, but I believe there are some folks who are currently working with the data up to like 2015. So it's a good question, Trish. You'd be comparing at least. Anyway, the short answer is as recent as we can get from what the hospitals have reported, and you can extract from the IRS or through GuideSource, however the data is going to get downloaded. And that varies sometimes by hospital and their reporting schedule, but to be complete, we're usually off by maybe a year and a half.
Great. So it's basically you'll be collecting the 990 information, the Schedule H information, and just reporting it as you get it.
Correct.
Okay, great.
Want to deal now with all of these questions, or are we waiting for Cynthia? There are many, many questions coming on.
We're definitely going to move on, especially around the ACA. So I just wanted to get the clarification questions answered, and I want to now move to Cynthia Woodcock, who has a particular focus on states. And I know most of you who are with us with states always have some skepticism about these community health needs assessments and whether they're really community health needs assessments linked to broader public health initiatives or more like marketing studies, and to sort of think about what a state can do around these issues, and particularly in light of a potential ACA repeal. And we'll talk more about the politics of this, but what is it that states can and are doing? And the Hilltop folks have been really front and center on this, and we're delighted that Cynthia Woodcock's here and can walk us through that.
Hi there, this is Cynthia. Very glad to be here. And I'd like to acknowledge our funders, who are also the Kresge Foundation and the Robert Wood Johnson Foundation. Also, the Maryland Health Services Cost Review Commission has funded some of our work here in Maryland around community benefit. Next slide, please. So I'm going to be talking a little bit about how states can promote community involvement in the community health needs assessment process, giving you some examples and ideas. Also, how you can use regulatory tools to incentivize a focus on social and economic determinants of health. How you can encourage hospital transparency and accountability. And then that big question, the repeal and replace, what are the implications for states? So I'll touch on that a bit, although it's a bit of an unknown right now. Next slide, please. So regional and community partnerships can go a long ways towards helping states to increase the effectiveness of the CHNA process. Multi-facility collaborations between hospitals and public health agencies are not only permitted but encouraged by the 2014 IRS final rules around community benefit. And in the original version of the ACA, Section 9007 instructed that the states need to take into account, or hospitals in doing their CHNAs, they need to take into account the broad representation of the community in developing their plans. And then the final rules went a step further. There had been a question about, originally it was said that hospitals, if they had multiple facilities, each facility had to do their own CHNA. But then the final rules came out and said that a hospital with multiple facilities can actually do one CHNA covering all of those facilities. So that's a really great mechanism for encouraging regional collaboration. Secondly, collaborations can help align hospital community benefits with public health planning and avoid duplication of effort. So there's some examples of states out there that are really aligning what hospitals are doing with their public health efforts that are very instructive. Also, you can really reach out to a variety of different partners in the planning process. Hospitals, physician groups, state and local public health and social services agencies, community stakeholders, health plans, private funders, and there are many, many more, all to be part of this planning process to make it more effective for the community. Next slide, please. So I have here a few examples of states that have some processes for encouraging or requiring community involvement in the CHNA process. In Massachusetts, the Attorney General has actually issued guidelines for community benefit that very expressly encourage hospitals to seek input from community groups representative of the population served. So this is an overlay on top of what the federal, what the ACA says, where Massachusetts is really pushing it. And they actually, the Attorney General of Massachusetts has actually given a much broader list of the types of organizations that could be included. That includes social services providers, community health centers, public health coalitions, neighborhood associations, local boards of public health, local planning networks, community action agencies, private charities, schools, churches, police, housing authorities, ambulance services. So, it can really be broadened. In Maryland, here in Maryland, we require the hospitals to consider CHNAs developed by state and local health departments and encourages consultation with community groups. And this is actually written into statute in Maryland. Texas, this is another case where a state has written into statute requiring hospitals to consider input from local health departments, public health districts, and community stakeholders. And in Utah, they mandate annual consultation with county health officials by hospitals and nursing homes as part of the CHNA process. And this is actually in the Utah Charitable Property Tax Standards. So they're coming at it from the tax standpoint. Next slide, please. So I wanted to give you a few examples of some successful regional and community collaborations. And this is just the tip of the iceberg. There's really a lot going on around the country now. Many of you probably have examples from your own states that we could put up here. But just a few to get you thinking. In Washington, D.C., the Children's National Health System has been working very hard to develop a collaborative effort across the D.C. area that's very focused on population health. And they've actually partnered with 4 hospitals and 4 community health centers. It's a formal partnership started back in 2012, and they're developing a citywide CHNA and implementation strategy. Second example is Baton Rouge, Louisiana. Here in Baton Rouge, they actually do not have a local public health department. So the mayor's office stepped in and has really brought the whole community together in a collaborative partnership where they're doing a joint CHNA and implementation plan and working towards improved population health is their goal. Thirdly, Carroll Hospital here in Maryland. Their theme is going from volume to value. And Carroll was one of the first hospitals in Maryland to move to a global hospital budget, which all the hospitals are on now here, but there was a small group early on. And Carroll used that opportunity to reach out to community providers for collaborations. And they've really made some amazing strides in improving hospital readmissions, reducing hospital readmissions, and improving a lot of outcome measures. Then there is Soccer for Success, which is an initiative of Trinity Health, and they teach the fundamentals of soccer to children in underserved communities, helping to establish healthy habits and help the kids develop new life skills. Next slide, please. And just a few more successful collaborations and community partnerships. Enos Park Access to Care Collaborative, which is in Illinois, Springfield, Illinois. This involves St. John's Hospital, which is a regional medical center, and also the Sangamon County Department of Public Health. And here they've done a comprehensive community needs assessment, and they've created the Enos Park Access to Care Collaborative, where they have community health workers who are actually going out into the community focusing on impoverished moms and kids, seniors. They're also partnering with local health providers and social services agencies. In Massachusetts, Franklin County, which is in Western Mass, the Communities That Care Coalition. It's a partnership between Bay State Franklin Medical Center and some of the local community, and they've developed this community coalition with priority areas around youth substance use and reducing risk factors for families. And then finally, an example from Tennessee, the Allies for Substance Abuse Prevention of Anderson County, Tennessee. And here the Methodist Medical Center and Ridgeview Behavioral Health Services have joined together with the goal of preventing substance use disorders. So those are just the tip of the iceberg on some of the kinds of things that are going on around the country. Next slide, please. Another thing that states are doing is using regulatory tools to encourage investment in social and economic determinants of health. And New York State has they have a statewide prevention agenda. And there are 5 priorities on that prevention agenda. It's around preventing chronic diseases, promoting a healthy and safe environment, promoting healthy women, infants, and children, promoting mental health and preventing substance abuse, and then preventing HIV, some other communicable diseases. So what they've actually mandated through regulatory tools in New York State is that the hospitals must focus on at least 2 of those 5 state prevention agenda priorities in developing their community health needs assessments. In California, statute there gives examples of community benefit activities that address social and economic sectors that shape health. So they're trying to give some guidance to states. It's actually right in statute. Also in statute in Maryland, we requires hospital implementation strategies to describe efforts to track and reduce health disparities. So again, these are regulatory tools. Go on, next slide, please. And also, state reporting can be very powerful in incentivizing the kinds of activities you want to occur in the state. New Hampshire, they have a community benefit reporting form that all the hospitals are required to use that requires them to indicate socioeconomic needs that they're addressing, such as poverty, unemployment, educational attainment, high school completion, vandalism or crime, homelessness, air quality, and water quality. And I might mention in New Hampshire, that state's community benefit requirements actually extend beyond hospitals to other kinds of organizations that they call charitable trusts. Nursing homes are in that category and some other kinds of providers as well. So moving on, next slide please. So one of the things that we've done here at Hilltop is investigated which states have their own hospital community benefit reporting requirements. And you can go on our website. We have our state law profiles where we actually go into each state and tell you what kinds of community benefit reporting they require. And essentially there are 31 states that have their own reporting requirements. This is on top of the federal requirements. And there's a lot of variation in how extensive or not extensive these are. But at any rate, there are 31 states that are out there now having hospitals report at the state level. And this really encourages transparency and accountability, and Sarah spoke about that some from the federal perspective. But I think there's a lot states can do to encourage it in their own state. Next slide, please. Here are just some examples of state reporting requirements that encourage greater transparency and accountability. For example, California hospitals have to complete a narrative section on community benefit activities. Vermont requires community benefit reports to be posted on both the hospital's website and the state's website. New York and Washington require hospitals to post implementation strategies on their websites. Indiana and Maryland hospitals must report on the effectiveness of community benefit initiatives. New Hampshire and Rhode Island require hospitals to report activities that they anticipate undertaking in the near future, so a little bit into the planning. And then Maryland, Indiana, and Texas can impose civil penalties on hospitals for overdue community benefit reports. Next slide, please. So how can states be more proactive in promoting targeted and collaborative hospital community benefits? We've already talked about some of the ways, but just to summarize, now that the process mandated by the Affordable Care Act is well established, I think we're seeing that hospitals are getting on a routine now of doing the CHNA development and implementation. And I think states can take more of a focus now on really pushing for these regional and multi-stakeholder collaborations, where you've got more facilities involved in joint planning and greater stakeholder participation in the whole process. Greater transparency. Some of talked about can help communicate exactly what hospitals are doing. One of the things Sarah was talking about is reporting the linkage between community benefit spending and the CHNA. This is something states could do. You don't have to wait for the feds to mandate it. You could do it in your own state. There are also the implementation processes and challenges. Now that states are getting into the CHNA routine every 3 years, they've got plans they're implementing. They're supposed to be coming up with evaluation plans and evaluations, taking a look at what their challenges have been as they've been going through the implementation process. On the evaluation, we need evaluations to assess whether desired outcomes are being achieved. What are those things they're aiming to achieve in their CHNAs? Are they achieving them? What are the outcome measures? And then finally, more comprehensive reporting by hospitals that goes beyond Schedule H and can be used to monitor progress with state health reform initiatives. So really there's a lot states can do above and beyond the federal reporting. Here in Maryland, under the work that we're doing with the Health Services Cost Review Commission, which is the entity that regulates hospitals in Maryland with our new global budget program, we're going to be working on how we can shape the community benefit reporting here in the state to reflect what some of the outcomes are the state's looking for with the new hospital all-payer waiver. So I'm sure there are reform initiatives going on in many of your states where you could creatively come up with measures and reporting to get a sense of to what extent hospital community benefit is contributing to your success. Moving on to the next slide. So finally, repeal and replace. Probably the phrase we're hearing the most this week and last week and next week and weeks to come. Where is this going to leave states? So if there was a total repeal of the entire ACA, Section 9007, which is the community benefit section, it would go away. And what would be eliminated? The requirement for hospitals to conduct the CHNAs every 3 years, as well as to adopt CHNA implementation strategies and conduct evaluations. And then also what we haven't been talking about today, but which has been really, really important, is it would do away with all the reforms related to financial assistance policies, limitations on charges to patients who are eligible for financial assistance, and billing and collections practices. The ACA put through a number of reforms in these areas that would be lost. Now, of course, we don't know if repeal and replace means repeal the whole thing or repeal parts of it, or just in a budget resolution, reconciliation, just the funding for now, and then you replace it later. So we really don't have any idea, but I would just put out there that potentially we're moving into an environment that is anti-regulation. This is regulation of hospitals. I think this could be a target for that reason. Also, there is a lot out there about potential tax reform. This affects tax policy. This could potentially be affected by that. I think the good news for states is that you do have the power to pick up where the federal regulatory environment leaves off. You do have the power to develop your own legislative and regulatory replace strategies in the event that Congress doesn't see this as a priority. So I would encourage all of you to look at what you're doing now in your own state and begin thinking about what you could do to augment that and have your own replace strategy if the need arose down the road. So those are my thoughts, and I think my next slide is just about Hilltop. And I just might mention, if you want to go on our website, our hospital community benefit program, there is a link to that, and we have the state law profiles. You may want to check out your own state. We also have a whole number of issue briefs that you may find helpful. And I will end there. Thank you.
Cynthia, great, wonderful, and a nice segue back to a series of questions. And again, I would encourage people to add your questions to the chat box. We are now in our Q&A session, so we'll keep up as best we can. But I think where Cynthia left off is where some questioners wanted Sarah and Maureen to weigh in. We have a new administration, perhaps less likely to be amenable to the IRS recommendations. As Cynthia notes, this the repeal and replace. You've been spending a lot of time, I'm sure, with hospitals. What do you think the future is here? What's your crystal ball?
So this is Sarah. I'm of a couple of minds on this. It is absolutely the case that the ACA amendments, which add the CHNA requirements and the EMTALA compliance requirements and the financial assistance and billing requirements, all are potentially exposed, just like the ACA in general is exposed. They're not costers, so they were given no score by the Congressional Budget Office, and so they would not be germane in a reconciliation bill. It could be that in tax reform, I suppose, the hospitals go after these additional requirements as a tax burden on them. But you have to remember that the chief proponent of all of this was Senator Chuck Grassley, who is, of course, a leading voice on tax policy, an extremely senior member of the Senate, and probably the most dogged pursuer of nonprofits in modern times. And I am sure that he will not have any appetite for changing the exempt organization amendments, and I don't think anybody else will, especially if what's also going on at the same time is a rollback and the scope of insurance coverage under as a result of the repeal of Affordable Care Act provisions. That's number one. Number two, there's an interesting way of looking at some of the changes on the community health improvement, community building distinction, and that is that by maintaining this wall between Part 1 and Part 2 and requiring hospitals to provide a lot of justification or some justification whenever they want to claim a Part 2 expenditure as a Part 1 expenditure, this adds to regulatory burdens. And in fact, when we did our health affairs blog that accompanied the release of the report, we made the point, we and Gary Young from Northeastern, who's probably the nation's leading authority on community benefit law and hospitals, made the point that you could look at this as sort of a deregulatory activity, making reporting simpler for hospitals, eliminating the need to have to go through this additional compliance reporting. I think probably the recommendation we make that hospitals show the relationship in their community benefit reporting between their community benefit spending priorities and the needs assessment would be seen as an added regulatory provision. That's the kind of thing that clearly, and Cynthia is totally correct, that none of this requires federal reforms at all. And certainly if I were interested in transparency at the state level, I would definitely be focusing on the value of having hospitals begin to have to do an estimate and draw a nexus for people to see between their community benefit priorities and their community health needs assessment priorities.
Great. Let me follow up again. In the chart from 2011, we see that the biggest expenditure for community benefit is obviously on charity care. If the ACA coverage goes away, the pressure will be back on to do just charity care. How could states and advocates position themselves to make sure that this great advance around community health needs assessment is advanced in that environment?
Well, I should note, if you look at the breakout anyway, that the vast majority already goes into charity care, and in fact, within that, the vast majority goes to unreimbursed Medicaid, and in fact, one of the questions is whether the charity care number actually is high enough. Meaning the unreimbursed, the financial assistance at cost. But putting that aside, in terms of sort of getting hospitals to dial up a little bit on the community health improvement activities, I would say there the most important step that might be taken is really this issue of we want to see how your allocation toward community health improvement is changing as a result of your needs assessment. Because in theory, if hospitals needs assessments are finding, as we have pointed out now just from reading their own needs assessments, that the social determinants are big problems reported by their communities. You would expect to start seeing an uptick here, and I mean, it seems to me that's a potential handle.
Yep. Actually, that's a good point, because Cynthia, you noted that Indiana and Maryland both require reporting on the effectiveness of community benefit activities. Do you have any more on that? How do they measure it? Because it seems to me that's critical to Sarah's last point.
I have Blair Innes with me, who is an analyst here at Hilltop. Blair, do you have any thoughts on that one? She's helped me with some of this research.
Yeah, I do. They look at outcome measures, really. So they don't report every year based on what outcome measures they're looking at.
Interesting. That certainly would be interesting to look at. And we would encourage. Oh, sorry.
I was just going to say too, and I'm hoping that as we get into our work with the state of Maryland, that we're actually going to be reviewing all of the hospital reports that come in. In fact, we've got the first batch of however many there are, 200 or something like that, hospital reports.
It's not quite that high, but yeah, it's a lot.
It's a lot. And so we're going to get a better sense of what they're actually reporting and how effective the instructions are for reporting and how we could refine it to get better information.
Great. Okay. And encourage people to add their questions, and seeing no additional questions, we'll wait a little bit. A reminder that we will be sharing all the slides and the recording, and we will stay in touch with Maureen and Sarah to make sure as soon as that website goes live, we will let you know. And make sure you have the link to Hilltop as well.
One interesting issue, if I could just sort of throw it out there, is I know, and this I'm sure comes up in the Hilltop work as well. There's always this interesting question: how much public health agencies are involved in the needs assessment process? You know, in theory, public health agencies could obviously be encouraging and working on unified needs assessments, and then sort of just the way we recommended a federal public health strategy around showing effective health improvement expenditures, whether this would be something for state public health agencies to do, that is to develop tools to help guide their hospitals toward more effective community health improvement activities through the kind of evidence base that maybe someday the Trump administration would use its own public health expertise to create, but certainly states could be doing it. And I just don't know if there's any state public health activity around this.
Yeah, I know there's state public health worry, because obviously as part of their new credentialing and as part of their activities, they do statewide needs assessments, and how to connect with these hospital ones has been a question.
Yeah, Trish, this is Maureen. There are some, not a lot, although Cynthia may know more about this. Some places are trying to get to align their calendars. You know, if the federal requirement about the community health needs assessment is every 3 years, and that depends on their tax year, and then the accreditation one is. There are a couple places around the country that are at least trying to see if they could get the timing of those aligned.
That makes sense. Okay. Unless we have more questions, I would ask if Maureen, Sarah, Cynthia have any last words of advice for our audience.
There is one. What is the timeline for the GW website to go live? I think, Maureen, you've given your best estimate, right? We just know it's sometime.
Yeah, as I said earlier, we've been conveying through the prototype process. It was clear to us from the feedback we received that in fact this was providing people with a resource that was helpful and useful, and so we've signaled that as quickly in a quality, good way it can go live, that would be great. But as any of you know about creating these web resources, they They sometimes don't go as quickly as we all would prefer, but our hope is sooner rather than later in 2017, but unfortunately that's as clear as I can be about the timing.
That's fair. Well, you can definitely tell your funders and others that there are 100 plus people on this webinar who are really eager to see it.
I will.
From your collective mouths to God's ears. So
that's it. That's the plan. All right. Well, this has been extremely, extremely informative. I really want to thank all of you. Thank Robert Wood Johnson for the support for this webinar. Again, we will post the webinar slides, the recording, and as soon as we know the go-live date for the George Washington University website, that we'll post these Schedule H's, and we'll keep you posted. Hilltop is obviously a great font of information for everybody, so that link is important as well. So thank you very much to Maureen Burns and Sarah Rosenbaum from George Washington University, to Cynthia Woodcock from the Hilltop Institute, and for all of you who joined us.
Thank you. Thank you.
Bye.
Bye.